and we might then leave the worst to last. I'm going to finish off. I've moved my talk to the end, just in the interest of rescheduling. So I'm going to give a very sort of high-level overview of a couple of other therapies. So we've talked a little bit about physiotherapy earlier on. We talked about non-motor treatments. We now talked about surgical treatments as well. So I'm going to give a very superficial overview of predominantly botulinum toxin, but some other medications for dystonia in general. So, as in talking to a couple of you at the breaks, I've talked about how different, and I sometimes sound like a broken record saying that everybody, even with the same subtype of dystonia, is very, very different, and the way in which it presents can be very different, and the way in which it responds to certain treatments can be very, very different. And I suppose it's also important to say that in spite of the fact that we understand the condition a little bit more, we still largely have treatments which treat the symptoms of dystonia rather than getting to the cause of what it is and stopping or reversing that cause. But there have been the treatment of dystonia has really revolutionized in the last few decades, predominantly because of the introduction of botulinum toxin, really. So we've moved towards it, and I think medicine in general is moving towards a sense of personalizing treatment, so that we would actually be individualizing treatments specifically to age, as we were talking about, for example, for deep brain stimulation, where the symptoms are, where the dystonia is most prominent, what sort of adverse or risk effects we want to avoid. And the treatments we would aim to treat would be the symptoms of dystonia, which would be the movements, postures, pain or discomfort, and then non-motor symptoms, which you talked about, Professor Peel talked about earlier on. So there are lots of treatment approaches, and I've sort of broadly put them into these sections. We've talked about some of them already. I'm really going to talk about the first two here. So it's fitting that we're in a 200-year-old room here, because it was probably about the time that this was built that the potential of Botox or botulinum toxin, as it's generally speaking known, was first recognized. But it wasn't until the late 1980s that it became approved in America by the FDA for treatment. I'll talk about how it works in a moment, but really the broad brushstrokes is that we try to weaken overactive muscles which contribute to the focal dystonia as a first-line treatment for it. As Professor Walsh said, we think of botulinum toxin as the first treatment for dystonia, and then if that doesn't work, we often think of other treatments as well. And there have been multiple studies. It's been very well studied about the benefits of it now. Any talk that you go to about botulinum toxin, or any book that you read about botulinum toxin, will have something along the lines of this. It'll say that the nerves and muscles communicate with each other, and the way they do that is you can see at the top of the figure there, that there's a small little gap between the end of the nerve and the start of the muscle, and the way that it communicates is actually by releasing these small little bubbles or vesicles, and there's a little chemical called acetylcholine which travels across from the nerve into the muscle and causes the muscle to contract. If this doesn't happen at all, no muscle contraction happens at all. But if you can actually control the amount of vesicles that release, well, then you might be able to make the muscle contract with less force. So it's a delicate balance of getting that right, and that's why you obsess about doses, for example, with botulinum toxin. However, we say this all the time to doctors and patients, but in actual fact, the way in which botulinum toxin works for dystonia is clearly much more complex than that. And there's probably some kind of a feedback mechanism that goes from the nerve or pain receptors to the brain and actually adapts it. So this was discussed at the International Symposium, and one expert has sort of said that it has happened that somebody gets botulinum toxin into one eye and for blepharospasm, and both eyes improve. And it's clearly not that it's diffusing across from one side to the other, but actually fact there must be some what we call a central mechanism of botulinum toxin that we don't really understand. So while we don't understand it, this is still what we say as regards how botulinum toxin works. And it's a reasonable way to say it, because we are targeting the muscles that are overactive and we are making them weaker. So it was first the botulinum toxin, there's different types of botulinum toxin. Botulinum toxin type A was first isolated in the 1920s. The proof of that mechanism of how it worked was in the mid-1950s. The first one for eye abnormalities, first therapeutic testing was in the 70s. And then, as I said, it was FDA approved in 1989, again for eye abnormalities predominantly. A little bit more understanding of how it worked. And then for cervical dystonia, it was approved for the FDA in 2000. And then we got into more other indications for it. And we're now at the point where we have a huge number of indications for botulinum toxin, which range not just from dystonia and other neurological conditions, but also things like urological and injecting botulinum toxin into bladders, even cosmetic, sweating, wound healing, etc. From a dystonia perspective, the main indications for it are for blepharospasm, or another condition which we call ilidopatia apraxia, which is probably felt to be a form of blepharospasm. So if you like, face, jaw, tongue, and around the mouth dystonia, which there are various terms for it, cervical dystonia, laryngeal dysphonia, which some people may have, dystonia of limbs, and then the task-specific dystonias, like as Professor Lang was talking about. So there are lots of indications for it. There are also different preparations of botulinum toxin. It's important to highlight that. Some of these are, just so you know what happens, some of these are supplied as a powder and they get reconstituted with a salt water solution. Some come reconstituted. And then when they're injected, it certainly takes, even for the biochemical changes to happen, it takes 1 to 3 days for that to happen. Most people here who receive botulinum toxin probably say that it takes about 7 to 10 days to work. Everybody's different, but you could probably set your calendar on the day that it's going to have its effect or that it's going to kick in. I've said here, because again, this is what will happen on every side, we'll say that it lasts 8 to 12 weeks, but I acknowledge that there are certainly probably people in this room who would say that it lasts either shorter or longer for them. And again, you could potentially set your watch by it, although there will be some variability from sets of injections to sets of injections. So there's 4 different types that are commonly used now. So the brand names of these are Botox, Dysport, Xeomin, and Myoblock. There are other formulations that are available and are coming on the market now as well. I'll talk about them in a moment. As I said, it's not really a cure, so it's a reversible treatment which treats the symptoms only. And the predominant target really is to improve quality of life. And I'll talk a little bit about how we go about trying to do that in a later slide. The challenge is, and one of the main goals that we're trying to do in alignment with trying to treat the symptoms, is trying to avoid side effects. And those side effects are real. They happen sometimes. We work as hard as we can to avoid them. But the side effects are really mediated by 2 things. One, that you overly weaken the muscle that you're targeting. Or secondarily, because it's a liquid and it diffuses into the muscles, you might get some of the toxin going into another muscle which you didn't want it to, and that causes unintentional weakness in a different muscle. So if you think about what would cause weakening, depends on where you're injecting, obviously. So if you get, you're injecting an eyelid and it moves into a part of the eye which keeps the eyelid up, you might get a drooping eyelid, and anyone who's had eyelids injected may have experienced that at some point. For cervical dystonia, the one that we often worry about is swallowing problems, because you have a lot of muscles in your neck, and they do a lot of things, and among that is coordinate swallowing, which is a very difficult thing to do. So you can get mild swallowing difficulties, or you can get more severe swallowing difficulties. Heads can droop or fall to one side a little bit. Again, a subtle thing, but you might notice that a head wants to fall forward at certain times. If it was, for example, for arm dystonia or hand dystonia, sometimes that can cause weakness, which can be disabling. If, for example, you can't write, or you're a concert pianist, or we talked about musicians dystonia earlier on, they're things which you just need to be very, very, very careful about. The other things are sort of a little bit more common sense, so bruising and bleeding. Some people can get systemic side effects. Infection is a very rare side effect. I've never seen it happen before. 2 days ago at the International Symposium, Buzz Jinnah, who's a really world-renowned dystonia expert, put up a slide like this of one of his own patients. This is just an image from the internet, and made the point that he would bring his fellows in to see this patient, and his fellows are all highly trained, and they would predominantly do the injections over in Emory where he works, and they bring him in to see this patient and say, what would you do? What muscles would you inject? And they would all say, well, obviously his head is being pulled to that side, so I'd target all of the muscles that would pull his head to that side, and that's how we do this. And every single one of them would say the exact same thing, and then he'd say to the patient, where does it hurt? And he'd point to the other side of his neck. And the point is that all of the experienced fellows who had seen it missed the point, which is that there are different complaints and symptoms that people have when they're getting botulinum toxin injections. And we really need to think about what the problem that we're trying to address is, rather than looking at it and trying to fix the mechanical problem that we see. Pain we talked about earlier on, and certainly botulinum toxin can have a good effect on pain, although it can be variable, and there's increasing evidence to suggest that it can have a very beneficial effect on pain if targeted correctly. But you need to target where it's painful rather than looking at the muscles, as I said, that are just looked to be overactive. So it may inhibit release of some substances that cause pain or make the brain sensitive to pain. It might change the way in which we process pain, not just in the nerves near where we're injecting, but also back in the brain. It may suppress some inflammation that can cause pain, and as I said, inhibit some neurotransmitters which mediate pain as well. The second thing that we always think about it is when people just are not responding optimally to botulinum toxin. So there are various reasons for this, and sometimes we try to address them. Sometimes the pattern of muscles that we're injecting isn't the right pattern of muscles. This is difficult because most people, and I've got to talk about cervical dystonia predominantly, there are other muscles that become active when somebody has dystonia that are not dystonic in nature, but they are sort of compensatory tightness of muscles. And sometimes you think a muscle is affected by the dystonia, when in actual fact it's actually just reacting to the tightness of all the other muscles. The other thing is that the dose may not be optimal, and sometimes we need to push that dose a little bit. And that's a very tricky thing to do, because what you don't want to do is then push the patient into the period where they're going to get side effects, or the dose at which you're going to get side effects. So always do that carefully, particularly when we're operating at a high dose. As Professor Lang was talking about, some people can get fixed contractions. Sometimes when you can't overcome that tightness of the muscle, that's something that may not respond that well, particularly when they're there for long periods of time. People often talk about neutralizing antibodies, and certainly at least one formulation of botulinum toxin can develop antibodies to these. It's actually quite rare for this to happen, but it does, and we sometimes keep an eye out for it, particularly if someone's clearly had a good response, and then that response starts to tail off. There's different, just to let people know how we go about this in the clinic. So there's different ways to target muscles, and one way obviously is, and the commonest way that's been done for decades, is really to know exactly where the muscle is. Some of these are big muscles, and target that muscle specifically using anatomical landmarks. So knowing exactly where we are in the skin, going in a certain depth at a certain angle, and we know that we can target that muscle. Increasingly around the world, people are using either EMG or ultrasound guidance to target muscles. Now, these are very helpful for certain muscles, for example, deep muscles in the arm or neck, or leg. And certainly in centres like in Toronto, they would have used a lot of EMG guidance. And Dr. Laura Williams, who's a colleague of mine from Sydney, they would have done a lot of ultrasound in Sydney as well. So just to give people a sense of how we go about this, so I was going to give a couple of examples of common conditions. So, as I said, everybody is different who has cervical dystonia, and that's largely because you have lots of muscles in your neck, and they all have different actions. So there's ones which can pull your neck to one side or the other side, can rotate your head to one side or the other side, forward or backwards, or a combination thereof. You also have a set of muscles which don't move your neck from side to side, but can actually move your head from side to side. So there are lots of different moving parts and lots of different degrees of freedom, and there are ways of saying, well, these are the muscles that I think would work, but there is an aspect of trial and error as regards targeting muscles and doses. Common ones that we would use would be the sternocleidomastoid, which is that strap muscle that goes down the side of your neck, or the splenius capitis, which is one that's a little bit more posterior even than it's shown in that. For blepharospasm, it's a little bit more straightforward because we tend to be targeting eye muscles, and there are places where we should try to target and places that we try to avoid. So we try to avoid the center of the upper eyelid because that's where the muscle that lifts the eye up is, and that will almost certainly cause a drooping eyelid, or ptosis as it's called. Some people suggest that we should avoid the inner lower lid because it can sometimes cause double vision, and certainly in Toronto they would have injected that area a lot, and I've actually never seen it happen, but we tend to sort of stay away from that if we can avoid it, but sometimes it can be helpful to add extra injections in if needs be. And then if somebody has, for example, arm or leg dystonia, there are muscles which do every movement, and we can always find that muscle and target it and inject it. And again, developing patterns over time is always an important developing the patterns of injections can be much more complex when it comes to arms and legs, largely because there are so many muscles involved. But there's certainly an infinite number of ways in which we can approach this. This slide which I put up, just some people may have heard that there are some longer acting botulinum toxins coming on the market, and they'll probably may come on the market quite soon. I don't know when they'll be available in Ireland. Daxabotulinum toxin, which is one of the ones that most people are talking about. suggests that it may have a longer mechanism of action, certainly maybe up to 20 to 24 weeks. Now, we'll need to see how this happens when it's rolled out and lots of people are using it, whether those numbers of weeks that are proven in clinical trials pan out. But if it's a longer-acting botulinum toxin, it will be certainly welcome, and we'll be able to do much more with it. It's nice to have another type of toxin in our armament for tackling, for example, people who, and a number of people have said to me that I'll get 2 months out of my injections and no more ever. It's nice to have something which might act a little bit longer. I'll talk quickly then just about medications, again in a much more broad overview, because some people may be taking time, some people may be taking medications for the treatment. So we talked about levodopa, or the dopamine therapy that Professor Lang talked about, used for Parkinson's disease. That type of dystonia, which has that diurnal variation he was talking about, it's often seen in children. We often know that responds very well. We call that dopa-responsive dystonia because it responds to this medication. And some other genetic forms can respond quite well, but it's important to say that most patients don't respond to levodopa who have dystonia. The most commonly prescribed treatment, or the one that tends to maybe have the most benefit, are this group of medications called anticholinergic medications. Artane is probably the one that's most prescribed, or trihexyphenidyl in Ireland, but other ones as well. They can work well. The effect can be variable. They can cause side effects sometimes, which is always that balance. It's a little bit like botulinum toxin. Again, I've had conversations with at least 2 people today who talked about really not tolerating this medication. But if you don't get side effects, they can be quite effective. The side effects we often talk about are maybe some confusion, dizziness, dry mouth, dry eyes, sometimes bladder retention, and sometimes feeling sweaty or feeling hot. There are other medications, baclofen. Some people may take this. This works on a receptor in the brain called GABA, often taken as a tablet, but again can cause tiredness and fatigue, because what we try to do is dampen down the excitability that's driving the dystonia. If you take a tablet, it goes into your bloodstream, it has to bathe your brain, and so it has other effects on the brain as well as that. We sometimes use, in combination with anticholinergics, benzodiazepines. The clonazepam is possibly the one we use most frequently, but other things like diazepam or Valium and lorazepam they work on the same receptors as baclofen works on, but in a slightly different way. They can work well, particularly in addition to anticholinergic medications, but sometimes anticholinergic medications are generally found to potentially be more effective. What we don't do that well is really measure how well people respond to treatments, and usually it's in a clinic. We ask people how they've been since we saw them last, and we get a sense of when it started, when it wore off, and how effective it was. There are rating scales, and Professor Walsh was talking about this TWISTRS, or this Toronto Western Spasmodic Torticollis rating scale, which you can quantify the degree of movement, for example, of neck posturing. We have, as Shamir had mentioned earlier on, we've done some studies measuring these, using these accelerometers to see how much movement or even tremor that people have, and people are working on this to have more quantifiable ways of saying how people respond to treatment, which will be helpful. Back to that point where what we're really moving towards is personalised treatment. So we will slowly but surely get a sense, and Dr. Lang was talking about as we understand the differences, as we lump people together who have dystonia and split them apart, that there will be certain groups, the reds, yellows and blues here, that will be able to say you're a red person and this is going to be the medication, or this is going to be the treatment that you're going to most likely to respond to. That's really all I have to say about that. I might see if there's any questions from the audience. I think we have a little bit of time for questions at the end.